So what does this look like? I have not asked for the diagnosis. When you are given an X-ray like this, what, this is a barium swallow X-ray of the esophagus showing narrowing or tapering of the esophagus at the lower end. So this is likely to be a case of, or probably a case of Achalasia cardia. You never know, this can be a malignancy as well. So never say Achalasia cardia directly. Okay, so what is Achalasia cardia? So it is basically a condition where the lower esophageal sphincter fails to relax. Right? So when we eat something, when we have a food bolus, it gradually goes down by peristalsis. Okay? So there is gradual opening of the esophagus and the upper part of the esophagus closes down. So it gradually pushes the food or fluid downwards. Right? So that is normal peristalsis. But if the lower esophageal sphincter is unable to relax, what will happen? So there will be we can see a narrow opening of the esophageal sphincter. Just above it, we will see a bulged out or a dilated part of the esophagus with the collection of the barium there. So this is like that. So the entire esophagus is dilated because the peristalsis is altered here. And then we see a narrow appearance. So what is this appearance called? Rat tail or bird beak's appearance. Both are correct. Okay. So it's a bird beak's appearance at the lower end of the esophagus. So now what is the cause of Achalasia cardia? Yes. So there is dysfunction, that is neural dysfunction of the lower esophageal sphincter. So what can cause this neural dysfunction? কি হতে পারে? কোন ডিজিজে হতে পারে বা কি কন্ডিশনে you will see this kind of patients of Achalasia cardia? So it's mostly idiopathic. Okay. Most commonly idiopathic, but it has been related to a few autoimmune diseases as well. And there is one particular disease called Chagas disease, which is found in Latin America. It's not found in India. So in that disease, you can see Achalasia cardia. Okay. So there is selective dysfunction of the neural cells of the lower esophageal sphincter, which causes this failure of relaxation of the ileus. Okay. Tell me a drug which increases the relaxation of the ileus. Nicotine. Very good. So mostly these questions are asked from this X-ray. Nothing much. Okay. Now treatment. Important. Sorry. Start with Botox. Yeah. So normally we try to do conservative procedures like balloon dilatation and sometimes Botox injections. So what does it do? The balloon dilatation, it dilates the ileus, but the problem is it stays dilated. So normal, what is the role of a sphincter? It prevents backflow of the acidic content of the stomach. So if you dilate, what will happen? The food will pass away, that's fine. But there will also be simultaneous regurgitation from the stomach. So there will be lot of reflux in these patients where we have balloon dilatations. Okay. With Botox, same thing. But Botox is usually shorter lasting than balloon. And then again, both of these procedures are temporary procedures. Anyway, over time, this balloon dilatation that you have dilated will again constrict back and cause the same problem because the nerve cells, the muscle cells are unable to relax because of neural dysfunction. Okay, so we cannot correct the neural dysfunction, to be honest. So for a definitive procedure, what do? We do something called a very good. So we do a procedure called Heller's myotomy. It's usually done endoscopic nowadays. So what we do an endoscopic surgery. We cut the lower esophageal sphincter. We actually do a myotomy. Myotomy means a partial resection. It's an otomy. So partial resection where there is this releases the tension of the muscles. Okay, and another thing he said is called fundoplication. Why do we do that? Yes. So after myotomy, there will be again this backflow. So what do we do is, so basically that. So this is supposed to be the esophagus. Okay. So there is constriction here in the ileus. So we are cutting it, doing a myotomy here. So what will happen? This will dilate. If this dilates, this content will easily go up and cause reflux. So what we do is, we pull it out and fix it somewhere here, so that the fundus is plicated. Okay, so it doesn't easily go for a reflux. Okay, so that's Achalasia Cardia. Yeah, so this X-ray, we asked this X-ray to a lot of students this year. No one could answer properly. I don't know why. This is a very, very easy one. What is this? Someone from the back volunteer, please. দেখতে পাচ্ছিস? দেখতে পাচ্ছিস? কি দেখতে পাচ্ছিস? Abscess কোথায়? আমি তো abscess কি দেখতে পাচ্ছি না। ভালো করে দেখ। At the first think of it. See, if I had to see an abscess, তাহলে আমি নাক নিতাম X-ray তে। If I had to see the abscess in the neck, would I have taken the nose in the cut? No, I would have taken the throat only, in the neck only. So I have taken the nose, nasopharynx, and the upper part of the oropharynx maybe. Not even the larynx is here. So we have not gone into the esophagus. Okay. So this is a lateral X-ray of the soft tissue nasopharynx. And what does this show? Okay. Enlarged adenoids. Okay. Adenoids are normal, everyone will have. Okay. So okay, you want to circulate this? তোর পেছন দিকে পাটা একটু পেছনের লোকজন দেখে নি ভালো করে। হ্যাঁ, আমি ছবিটা এঁকে দেখাচ্ছি। পেছন দিকে একটু ওরাও দেখুন একটু। চকটা কোথায় হবে? So you have the nose here. So this is the skull base. The sphenoid sinus goes in like this. So this is the nose. So here lies the adenoid tissue. If we have the palate over here lies the adenoid tissue. Okay, and so normally in childhood we have larger or smaller adenoids? Larger adenoids, okay. But what happens over time? The tissue involutes. Okay, so adenoids are a part of what ring? So these are lymphoid tissues, a part of the Waldeur's ring. So their normal function is immunity. So they help in immunity. But what happens is, in kids particularly, if they have very enlarged adenoids, very large adenoids, they are unable to breathe through the nose. Okay, so these adenoids, if they are very much enlarged, sometimes they can cause complete obstruction of the choana, like in grade 3 or grade 4 adenoid enlargements. So what is the problem then? The child is unable to breathe through nose properly. So tell me, just think about it and tell me what are the symptoms Apart from difficulty in breathing, of course, what are the other symptoms the child may face? আস্তে আস্তে শুনতে পারেন জোরে। ইউস্টেশিয়ান টিউব ডিসফাংশন হতে পারে, ওকে, আইল কাম টু ডিটেলস, ভেরি গুড। আর কি হতে পারে? ইউস্টেশিয়ান টিউব ডিসফাংশন হয়ে গেল। ব্লিডিং অ্যাডিনয়েড থেকে হয় না, বিকজ it is not a raw tissue like that. Infection hote pare, there can be adenoiditis, but usually it is not very symptomatic. Say infection hole, the only symptoms that we get is it enlarges further. So there is swelling and more inflammation, and it enlarges further, causing more obstruction. So that is very important. So their nasal secretions, normally what happens is the nasal secretions goes posteriorly. The secretions go posteriorly and we swallow it without even knowing it. So a child with very big adenoids, where the choana is completely obstructed, the secretion will be collected in the nose. The child won't be able to swallow it. So either he will have persistent nasal discharge, খুব কমন, গ্রামের দিকে গেলে বহু বাচ্চা দেখবি সারা বছর নাক দিয়ে জল পড়ে, very very common. Okay, so because they are unable to swallow the nasal secretion, the nasal secretion doesn't go back, and there is recurrent sinus infections because sinus টা কি হবে, it's unable to drain properly. ঠিক আছে, আর কি হবে? কি হতে পারে ভাব, নাক বন্ধ তো, ইউস্টেশিয়ান টিউব ডিসফাংশন তো একটা বললি, ব্লিডিং হয় না ইউজুয়ালি, অ্যাডিনোইডাইটিসে শুধু ব্লিডিং হয় না, আইসোলেটেড অ্যাডিনোইড এনলার্জমেন্টে কোনোদিন ব্লিডিং হয় না, আনলেস ইট ইজ কমপ্লিকেটেড বাই ইনফেকশনস, তাও ইট ইজ ভেরি রেয়ার। ইউস্টেশিয়ান টিউব ডিসফাংশনের জন্য সেরাসোডাইটিস মিডিয়া হবে, and if it gets secondarily infected, the child may have a acute otitis media. Okay, so serosorrheitis media has sterile fluid. Acute otitis media will have an infected fluid or a pus. A single episode of acute otitis media is an indication for adenoid surgery. ঠিক আছে, তো যদি একটা বাচ্চার serosorrheitis media হয়, you can do grommet or you can just wait, do some, because over time we know that the tissue will involute, the tissue will gradually go down, right? So that's the point of treating an adenoid conservatively. তাই তো, আমার কাছে একটা 6 বছরের বাচ্চা এলো with adenoid enlargement and symptoms. So we do not always operate. We assess the degree of obstruction, whether it is a complete choanal obstruction or what kind of symptoms the child has. So another thing is, since the patient is unable to breathe properly, there will be sleep issues. There will be snoring, and the child will always breathe through his mouth. Okay, so he'll sleep with his mouth open. So we always ask the parents, when a child comes with a suspected adenoid enlargement, we always ask the parents, বাচ্চা হাঁ করে ঘুমায়, নাক ডাকে? These are two very important questions. Okay, so if a patient, if a kid or any person is a chronic mouth breather, what will you see? There is something that you will find, high arched palate. So adenoid enlargement patients will mostly have high arched palate, and there is something called adenoid facies. Okay, so because of this chronic mouth breathing and improper sinus drainage and poor sleep, there will be some alteration of the facial growth. Okay, there will be depressed nasal bridge, broadening of the nasal bridge and all. So there will be adenoid facies. Okay, adenoid facies is not something that you will appreciate all the time, but we usually tend to treat based on the symptoms. So it is not a fatal disease, to kharap rog noy. So we ask the symptoms, how bad the symptoms are. So if the adenoids are very severely enlarged, the parents usually say, no sir, he cannot sleep at night, mostly he will wake up repeatedly, he will breathe through his mouth, he will grunt. The problem is, most of the times, there is no isolated adenoid enlargement. It is almost always, or most of the time, associated with tonsillar enlargements as well. So we call it an adenotonsillar hypertrophy. right? So if there is adenotonsillar hypertrophy, just think of the situation. Your oropharynx is blocked by enlarged tonsils. Your nasopharynx is blocked by adenoids. How will the kid breathe? Okay, so there is something called failure to thrive. The kid is unable to have a proper sleep. The kid is inattentive at school. Because of Sinusitis media, patient will have poor hearing. Okay, so all these symptoms considered together will tell us the severity of the problem and what is the treatment of adenoid enlargements. How do we do it? So what are the conservative measures? Is there any conservative? Decongestion. Okay. Yeah. So that will decrease nasal secretions and all, but antihistamines will not get the adenoids down. So we use something called intranasal corticosteroids. X-ray হয়েছে? দেখে দিস সবাই? গেছে লোকজন দেখছে? So we use something called intranasal corticosteroids often to start with. Okay, so it decreases the overall inflammation, and sometimes then we can just wait for the symptoms to go down because of involution over time. Okay, but if he has significant symptoms, we go ahead and operate. So we do something called adenoidectomy. So how do we do an adenoidectomy? Okay, so there are basically two methods on both tonsils and adenoids. We can do it a hot or a cold still method. Okay, cold still method is a classical method for if I do an adenoidectomy. What is the procedure like? So what we do is we take the patient in a tonsillectomy position. You know the tonsillectomy position, right? The roses position where there is extension of the neck. So we put the patient in the roses position. Okay, so what happens is the nasopharynx becomes the most dependent part because the head is down. So nasopharynx is the most dependent part. So now we take something called a adenoid curette. So it's like a saw basically. Okay. So it looks like, have you seen an adenoid curette? So it basically looks like this. And a blade over here. So we go in, we try to hook the adenoid tissue inside this blade and shave off the adenoid. The difference between adenoidectomy and tonsillectomy is adenoid doesn't have a capsule. In tonsils, we can do extracapsular or intracapsular tonsillectomies. Okay, because tonsillar tissue is very oriented and very clear cut. It has clear cut borders or margins, but adenoid tissue doesn't have any clear cut margins. Okay, so we shave it off from the nasopharynx and we expect the inflammation to go down over time as the child grows, because anyways it's very unlikely that the adenoid tissue will enlarge with age. Okay, but the problem that used to happen is earlier when we used to do this cold steel method, because this was a blind procedure, right? We are just palpating the adenoid, putting in the guard and the curette with the guard, and then taking the adenoid tissue out. And we use something called a PNS mirror or a laryngeal mirror to see whether we have removed all the tissues or not. Okay, but what happened is we always used to leave behind some adenoid tissue. And if you are doing the adenoidectomy very early, like 3-4 year kid, failure to thrive, we have to do an adenoidectomy. They will have 7 or 8 years more. In this time, the adenoid tissue may regrow. Okay, so nowadays we have almost stopped doing cold shear adenoidectomies. What we do is something called a Coblation adenoidectomy. So it's something that is visually guided. So we use an endoscope through the nose to see the nasopharynx, and we have a coblator. The coblator has a wand like this. It's a straight wand which is a little curved upwards. Okay, we use the wand. So coblation is basically a radio frequency technique. So it creates a plasma between the tissue and the probe, and it evaporates the tissue. It eats up basically. Okay, so coblation diye we usually eat up the adenoid tissue, and see we don't have a capsule like I said. Okay, so we have to be very careful about how much tissue we are removing. So buccopharyngeal fascia, the fascia that comes here posteriorly, it's a typically whitish plane that we have. We usually take it out in that plane. Okay, so post adenoidectomy, what are the chances, what are the complications, and what are the things that can happen? Bleeding, very common, and probably that is the only complication of adenoidectomy. Adenoidectomy doesn't have much of complications. Okay, because it's high up in the nasopharynx, so there is no problem, no dysphagia or something, because the food doesn't go in there. Okay, so the only complaint the child may have is a little bit of pain and bleeding off and on. But usually adenoid bleedings are very benign, and if you use some decongestants or hemocoagulase drops or something, it usually goes down. Okay, it's a very simple surgery and a very rewarding surgery for the patients. Okay, but if you have always in patients of adenoids, you have to assess the tonsils as well. So if there is tonsillar enlargement, we'll do a adenotonsillectomy. Okay, so there was once a theory that we should not use the term adenoidectomy because we are not removing it with the capsule. How much ever we are removing, we will always leave behind some tissue because there is no definite capsule. So our teachers used to say that call it adenoid removal, tonsillectomy with adenoid removal. But common colloquial term is adenotonsillectomy. Both are correct. If you say nothing, I mean, I'm just letting you know that this is the point because adenoid doesn't have a capsule. So now we'll come with the famous X-ray. I think this is the only X-ray everyone could answer. A few were wrong, but most of them were right. So what is it? This is not how you say it. Tell me how you say it in the exam because that's important. X-ray of neck, chest and upper part of the abdomen. Very good. Slit-like. Coin will be not. It can be anything. You say a radiopaque circular foreign body. Okay, a flat circular foreign body. Probably a coin. You can add probably a coin, but don't say coin directly. Okay. So, like I said again, what are the symptoms that the kid will have? Dysphagia, and sometimes they are asymptomatic as well. Okay. বাচ্চারা কিছু বলেই না usually. দিব্যি খাচ্ছে যাচ্ছে সব কিছু করছে because the coin is slit like and there is enough space around. The food and water will pass. They may be asymptomatic at times. Okay. So, I heard one external examiner ask this question, so I wanted to clarify. So, where do you think, at what, based on this X-ray, this particular X-ray, at what level do you think is the foreign body stuck? Oh my polish, huh? What is it called? Pharyngoesophageal junction, there is a name for it. It's called the cricopharynx. Okay, so it is stuck at the cricopharyngeal sphincter. You know the constrictions of the esophagus, right? So this is the first constriction. So it is stuck in there. Why do we say that this is in the esophagus and not in the trachea? ঠিকই বলছো. Yes, very good. Actually, that's not how you say it. That's right, actually, but you don't say it like that. So what they want to know is the relative position or relative, orientation of the foreign body. Okay. So what will happen if the foreign body? What would have been the shadow like if the foreign body was in the trachea? You understand the difference between these two? বুঝতে পারছিস ভালো করে দেখে? সবাই বুঝতে পারছিস, ভুল হবে না এটা? Okay? You should never get this extra wrong at least. It is given to alternate students. দেখাচ্ছি. We have one X-ray like that. এটা না একটা সুন্দর ইস. So this shows both the images, AP and lateral. কোনটা esophagus কোনটা trachea? এটা esophagus. এটা esophagus. এটা trachea. Okay. Why are you saying that the orientation is like this? Why does the orientation is always like this? That is the point. So, so the vocal cord, if you see, this is anterior and this is posterior. The vocal cords are like this, right? This is the adenoids. Okay, so a foreign body cannot go in like this if it is larger than the size of the lateral dimension of the glottis. So it has to go in like this because this is much longer than this one. So our glottic chink is slit like. So the foreign body has to be in this shape to go in the trachea. If it is like this, it will get obstructed. And the patient will cough out and it will go into the esophagus. But if by chance it is going, if the patient is breathing at that time, vocal cords are wide open and the foreign body is in this orientation, then only it will go down the trachea. So once it crosses the vocal cords, sometimes even if the patient tries to cough out, so what happens when you cough out? Your vocal cord touches each other, it creates the pressure and then it opens. Okay, so when it creates the pressure, so if a foreign body goes into your trachea, you will try to cough out. That's a reflex. Okay, but this is big enough for a kid's trachea, so it gets stuck. First. Second is, even if he tries to cough it out, sometimes it gets obstructed by the glottic chink. So because the glottic, if you see, this is trachea, this is the larynx. So glottic chink is like this. Both the vocal cords from both sides. So the foreign body is like this. So it had to exactly go like this to get out, and which is almost impossible. So even if the child coughs, sometimes it is stuck in there. But what happens in the esophagus? So if this is the trachea, the larynx, the esophagus is like this. It's a muscular structure and it is anteroposteriorly flattened. Okay, and since a muscular structure, it can open up. So if something comes into the cricopharynx, it opens up and the kid swallows it. It thinks that it is a food, so it opens up and the kid swallows it. Okay, so what do you do for esophageal foreign bodies? What procedure do you do? Endoscopy only. There is a particular term that you need to use. It's called a rigid endoscopy. We are not doing a flexible endoscopy here. If it is a coin, sometimes we can do a flexible endoscopy, but it is preferred. A rigid endoscopy is always preferred. Okay. In a flexible endoscopy, we are seeing under a camera. We are using a flexible scope and we can visualize with the camera. We can reach the foreign body and take it out. But in case of rigid endoscopy, we have a direct visualization of the foreign body. Okay. So in coins, it is not very bad, but if there is some other foreign bodies with sharp edges and anything, if you have a flexible scope, you are holding it and trying to pull it out, that sharp edges can cause injury to the esophageal mucosa, and the mucosa is the strongest layer of the esophagus. So if you are causing tear of the mucosa, you are damaging the esophagus. So what you need to do is use a rigid scope to get in there. We hold the foreign body, try to take the sharp edge within the esophagoscope and then pull both the things out together gradually. Okay, so for foreign bodies, try to mention rigid esophagoscopes. What happens if it is in the bronchus? Rigid bronchoscopy, very good. Okay, so remember one thing, at your level, flexible is mostly diagnostic. For foreign body removal or something, rigid. No one will question you. Yes, nowadays we often use even flexible for removal of meat bones and a lot of things, but that is not something you should learn. We do it because we know that yeah, we can safely do it, or there is enough, we can safely hold it and all. If the surgeon or the gastroenterologist is very much confident that he can safely do it, then only we do it. Otherwise, the rigid is always preferred. Or sometimes if it is very low down somewhere, say beyond the or in the stomach, okay, or beyond the pylorus somewhere. So you can't do a rigid. You have to do a flexible only, or you will have to open up. Okay. Well. So this is both the views you have, na? So you have both the views. If it was outside, on the lateral image, you should have seen it outside. It cannot be. I mean, this is very clear cut. On one image, you may not be able to see. If you are only given this image, then you cannot say that this is definitely in the esophagus. So if they ask you, tell them that we'll need another X-ray. If this is a lateral view. If they ask you, we'll need an AP view to confirm, sir. We'll have to do a AP view to confirm. But that is a ridiculous question. A child has come to you with a foreign body and you are just, that is, you can just check for yourself whether the kid is wearing something metallic there or not. You have to do the other view. If you are given a lateral view, then you can do. So for the examiner will say, okay, it can be here. We're taking a lateral view. So you always do the other view. If there is an AP view, do a lateral view. If it's a lateral view, do a AP view. That's it. Plain and simple. So that solves the problem. There's no issue with it. Can go. If it is very small, it can go. Definitely can. But that the object has to be very small. Because the child's glottis is very small. It's not an adult. We don't usually take in coins and swallow, right? Or accidentally we can. So we have seen a lot of patients, inhaling things, going into the bronchus. Particularly, তোরা দেখেছিস আগেকার দিনে গ্রামে যে মেলা টেলাতে বাঁশি বাজাতো না, তো অনেক সময় না ওই বাঁশির যে পার্টটা বাজে আর কি ভেতরে, যেটা তোর ইয়েটা থাকে, হোয়াটস ইট কল্ড, নোজেল লাইক থিং একটা জিনিস থাকে যেটা থেকে আওয়াজটা বেরোয় বেসিক্যালি। বাইরে তো বাঁশিটা বড়, ভেতরে জিনিসটা ছোট্ট। সো ইফ দে আর ব্রিদিং ইন, সাডেনলি ওটা যদি লোকাল জিনিস খুলে যেত, ভেঙে যেত অনেক সময়, ইট উইল স্ট্রেট অ্যাওয়ে গো টু দ্য ট্রেকিয়া। And the patient will come in your OPD, sit in front of you with a whistling sound on breathing. We have seen these patients. All of us have. The patient, আমার কাছে ভিডিও ছিল একটা. If I get some time, I'll show you once. So send it to someone of you so that you can see. So the patient is breathing and there is a whistling sound going on. First of all, there is confirmatory that the foreign body is in bronchus or trachea or bronchus, somewhere in the airway. Okay. So another thing that will tell you whether it is in the esophagus or, say, not a coin, say whatever, any other foreign body. We have seen LED bulbs, we have seen everything. Okay. So say, we don't have an X-ray of that now. So say in this X-ray, okay, let's take this X-ray and say the foreign body is here. Yes. So this is a very important DD. If you have a foreign body on an AP view, not in the midline. It is not in the esophagus. The esophagus will be very close to the midline. Okay, when it is away from the midline, it cannot be esophagus. So it can be anywhere in the airway, or it has perforated the esophagus and come into the mediastinum. Okay, a very famous surgeon, I will not name, we have seen of taking in a case like this, and the patient had fatal complications because developed severe mediastinitis. Okay, so emergency things can happen. So it was a battery that the patient took. That's what I was talking about. We have an X-ray of that. See, LED is a LED bulb. দেখতে পাচ্ছিস সবাই? So here, the foreign body is not in the midline. Okay, it is away from the midline. So esophagus will be in the midline, right? So it cannot be esophagus. If the patient doesn't have any symptoms of mediastinitis or any other issues, then it is probably in the airway, because what happens is the trachea comes and it bifurcates into the right and the left bronchus. Which bronchus does the foreign body usually go in? Why? It is straighter and shorter. So the foreign body is usually more often they go to the right bronchus. It can go to the left bronchus as well. There is no absolute rule it has to go to the right bronchus, but most often we see it in the right bronchus, because it is the division is usually like this. If you actually see a scan or something, so division is actually like this. So it's much easier for the foreign body to go into the right bronchus. Even when we are doing a bronchoscopy, it is much easier for us to see the right bronchus than the left bronchus. Okay. So what procedure do you do? Rigid bronchoscopy. Okay. Direct visualization and taking the foreign body out with grasping forceps. Barium swallow is something that may not, because if say barium swallow is a liquid, right? It's a fluid. So if you have a foreign body, the fluid can go on around it and make it completely opaque. First. Second is the foreign body may not be ready opaque. It can be anything. Tableted morok hai na? See this alu packs or this kind of packs for the tablets, you see. So I have seen elderly people, they have taken the tablet out. Instead of putting the tablet in the mouth, they have put the other thing in the mouth, the wrappers. Another very common foreign body is artificial dentures, particularly in elderly individuals. So while drinking water or something, this denture will go in. So these are mostly acrylic. So you won't see on X-ray. But sometimes it is attached with a wire. So the wire usually comes on X-ray. But if we absolutely cannot see it and the patient is saying that I have surely taken it, either you go for CT scan or something. CT scan will also not pick up properly, because CT scan is just a modified X-ray, nothing else. But it gives a better visualization of the soft tissue. So it might take up, otherwise you directly go for a esophagoscopy and find out. You may do a flexible there to see whether it is already there or not, and then do a rigid proper to take it out. Okay? বুঝতে পারবি না কোন ছবিটা? What is the anesthesia of choice? What is the anesthesia of choice? You tell me. কোথায়? The foreign body is in bronchus. Okay. So if you keep the patient absolutely conscious under local anesthesia, do you think you will be able to enter the bronchus? No. So we will put a general anesthesia, but we prefer to keep the patient on spontaneous breathing. I don't think we expect this answer from you, but still I am telling, since we are talking of this, you can say general anesthesia, almost always bronchoscopy under general anesthesia, but preferably the patient will be on spontaneous breathing. So there will be relaxation, there will be general anesthesia without complete relaxation. So what is the advantage? So have you ever seen a bronchoscopy? I don't think you have, right? So what we do is, in a bronch, we put the general anesthesia. So we deeply sedate the patient. We don't go to level 3. We deeply sedate the patient somewhere around 2. Okay. Then we put the tube. Then we ventilate adequately. So once the patient is properly ventilated, we use the anesthetist laryngoscope. Okay. We see the glottis. We take the tube out and then put the bronchoscope through it. Okay. So the child is apneic now. If it's if he is on spontaneous breathing, then he is probably breathing. But if he is not on spontaneous breathing, he is apneic. And usually the diameter of the bronchoscope is such that it almost completely occludes the lumen of the airway. So even on spontaneous, the child cannot breathe adequately. So you have to be very fast. Bronchoscopy will give you 30-40 seconds to go in, see the foreign body, grasp it and take it out. So sometimes we cannot complete in 30 seconds. Then what we do? We take out, we again put the tube, again ventilate, again take the tube out, put in the rigid scope. There is something called a ventilating bronchoscope, where here, like the bronchoscope, there is, so the bronchoscope looks like this, right? It's like a rigid tube. We have a handle in here, some handle in here. So there will be holes here. And there will be an opening to put the anesthesia gases or oxygen. Okay. So when we have already put the bronchoscope in, they will just connect the wirings with the tubes with the bronchoscope. And because of these holes around, there will be ventilation going on while we can see that gives more time for us to see the foreign body properly, hold it, take it out. The child will not be apneic. Okay. And usually, so you need a closed circuit, right, for ventilation. You need the circuit to be closed. So this side is open, right? So there is usually a glass cap. So when going in, we keep the cap there. You can see through the glass. When we reach the foreign body, we can locate it. Then we just remove the cap, use the instrument, take the foreign body out, put the cap in, continue ventilation, gradually take it out and then replace with the tube and gradually reverse the patient out. Okay, there are so many questions can be asked on this. Usually they don't go this far. The basic questions are usually asked. তারপর পলিপ তো হয়ে গেছে, বাকি এক্সরে গুলো কোথায় গেল? নাকি it's the same x-ray again. কোথায় esophagus না bronchus? Esophagus. Very good. এক করিস না. So there is a better x-ray of the adenoids. So this tissue is the adenoid. So this is the nose, the nasopharynx. Always trace it. See the nose, trace it behind. Here you encounter this tissue. So it is obstructing the nasopharyngeal airway. So this is the adenoid hypertrophy. So we go to here. What time it is? I don't think we have enough time for. Let's do this one at least. এটা একটু সবাই হাতে দিয়ে দেখতে হবে. You won't be able to appreciate it from here. These questions will not be the same for every batch, okay? We will obviously change it. So don't go with the questions. Don't take photographs of the questions. That will change. না আমাকে বলে নি একটু এক্সট্রা তারপর দেখিস ফ্র্যাকচারটা বলছি ওটা দিচ্ছে কিছুই বোঝেনি আলো. So this is a sciagram or x-ray of কিসের এক্সরে এটা? ল্যাটারাল ভিউ অফ স্কাল বা ফেসও বলতে পারিস, showing, so obviously you cannot see, very sorry. So there is a fracture of the nasal bone. You can see fragments of the nasal bone. So it's a displaced fracture of the nasal bone. I'll circulate this X-ray for every one of you to see properly. Okay. So there is a displaced fracture of the nasal bone. Why this displaced is important? Why this displaced word is important? Okay, so what will be the difference in treatment? Say a child has come to you with an undisplaced fracture and another child has come to you with a displaced fracture. So in undisplaced fractures we don't need to operate or do anything? Okay, so in undisplaced fracture we obviously do not need to reposition it, but we need to make sure that the fracture fragments are aligned properly and they do not, by any means they don't get dislodged. Fracture হয়ে গেছে তো, so they are broken small fragments, so they will easily get dislodged. So we use something called external splints. যেরকম হাতে POP হয় fracture হলে, so we use a POP splint. So nowadays plastic and PVC splints are also available. So we use a splint to cover it so that there are no trauma, and we tell the patient and the family that you should be careful that there shouldn't be any trauma. Any trauma will cause a permanent deformity. Then we'll have to go in, operate and fix it again. And what about if there is a displaced fracture, the patient has come to you after 5 days, what would you do? Remove করে দেবো, নাকটা তো cartilage টা, fracture nasal bone মানে fracture of the bone, reposition করবো. So what happens is, for the first 24 hours the inflammation is minimal and then it starts to inflame. Okay, so for the patient comes within the first 24 hours, we usually do a surgery immediately. But once the inflammation starts, what happens is there is a lot of swelling, and even after repositioning, we will not be able to understand properly whether the repositioning is correct or not. So usually we wait for 7 days to 2 weeks, so 1 to 2 weeks, preferably after 2 weeks, once the inflammation completely settles down. শুনছিস না সবাই কি বলছি বলতো? So তোকে বলতে বলিনি, তুই সামনে শুনতে পাচ্ছিস আমি জানি. So what happens is, after 2 weeks the inflammation goes down. A patient has come to you with a fractured nasal bone, so there's a lot of displacement there. Okay, so the patient has come immediately, the inflammation has not set in yet. So you have time, you go to the OR, correct it properly, fix it with the splint, and you are done. It's fixed. But if the patient has come to you after 3-4 days, say, so there will be a lot of inflammation. There will be blood clots, swelling, hematoma and all these things here. If you try to fix the bone at that point of time, after fixing, would you be able to appreciate whether you have fixed it correctly or not? Because everything is swelled up. So what we do is, we wait for 1 to 2 weeks. Once the inflammation goes down, then we take the patient to the OR, do a refracture and correct the position of the bones. It's easy if the patient comes immediately, because the bones are already fractured, you can easily reposition it. So what are the instruments that's used for nasal fracture repair? So I'll show you in the instrument class. There are 2 forceps called the Ashes forceps and the Walsham forceps. Okay, remember the names at least, they are asked frequently. You will get it in your book, in Dhingra it is there. So Ashes forceps and Walsham's forceps. We use those instruments to correct the fractured nasal bone. Those instruments are also used for rhinoplasty. কান পড়বি? কান শুরু করলে আবার 1 ঘন্টা at least লাগবে. কান ear will take time, because we'll have to compare different Okay, one last X-ray we'll do today. What is this? Very good. So this is a very nice X-ray. Actually, এত ভালো X-ray পাওয়া যায় না. It's a very nice X-ray. It's a classical retropharyngeal abscess showing air fluid levels. Can you appreciate? সবাই বুঝতে পারছিস? খুব সুন্দর দেখা যাচ্ছে, এত সুন্দর দেখা যায় না। See, this is the airway anteriorly. একটু কাছে গিয়ে বলি। So this is the airway of the trachea anteriorly. So behind that there is the esophagus, and the abscess is retropharyngeal. So it's behind the pharyngeal wall. So what is the cause of a retropharyngeal abscess? So you can see the airway. Trachea দেখতে পাচ্ছিস সবাই, এদিকে লোকেদের জন্য বলছি, trachea দেখতে পাচ্ছিস সামনে। So trachea there is absolutely normal, nothing in there. So nothing related to the airway. Behind the trachea, what is there? The esophagus and the posterior pharyngeal wall. So behind that there is collection of fluids or pus. How do we know? ভালো করে দেখলে দেখবি there are air bubbles. এক্সট্রাটা যদি ভালো করে কাছে নিয়ে আমি দিচ্ছি তোদের, এক্সট্রাটা যদি কাছে নিয়ে দেখিস দেখবি এই ফ্লুইডটার মধ্যে, ওপেক শ্যাডোটার মধ্যেও, so there is an air fluid level. ওপরে হাওয়া, তলায় fluid. So there is an air fluid level. Apart from that, there are multiple small air bubbles within the fluid shadow. What causes these air bubbles to be there? So what is in there? There is an active infection, right? So there will be microorganisms. There will be anaerobic organisms, anaerobic organisms. So what will they produce? Gases. Okay. So we will see this bubbles, air bubbles inside the fluid part. Okay. So what is the cause of the retropharyngeal abscess? What are the common causes of retropharyngeal abscess? কেন হয় retropharyngeal abscess কেন হয়? কিছুটা হতে হবে একটা ওখানে তো, হ্যাঁ? After pharyngitis না এতটাও, মানে if the patient is grossly immunocompromised, something like that, but I've never seen. I mean, it is not like that. It's usually a neglected foreign body in the pharynx. So if there is a foreign body impinged in the pharynx or stuck in there, it will cause an inflammation, and there will be infection associated because you are breaching the mucosa. The infection will go in posteriorly and will cause an abscess in the retropharyngeal space. Other than that, what can be other causes? So what is the content of the retropharyngeal space? So there are lymph nodes, right? So lymph node, if there is any infection of the lymph nodes, most commonly tuberculosis, there will be caseous necrosis of the lymph nodes that can cause abscess formation, tubercular abscesses. But to be honest, based on this particular X-ray, I will not call it a tubercular abscess because tubercular abscesses are very slow growing abscesses and they don't have this much of air fluid level. This is classical of an acute abscess. Okay, so what will you do if you have a retropharyngeal abscess this big? You are instant drainage করবি, ইনসিশন দিলি, পাঁচটা ট্র্যাকিয়ার মধ্যে চলে গেল, the patient aspirates and dies on the table. What will you do? কি পজিশন হবে? Reversal, very good. So we try to keep the head down. Position the patient in such a way that we try to keep the head end down, and preferably under local anesthesia. Why? the patient will cough out. But if you have to put a GA, sometimes it is impossible under local anesthesia in some patients. If you have to put a GA, you have to inflate the cuff enough to complete this, seal the airway. And then we do nick the mucosa, open up the spaces properly and drain the abscess. Okay. We may use local antibiotics and local anaerobic agents there, but the patient will definitely need what? What are the medications that he will prescribe? কি ওষুধ দিবি? Antibiotics দেবো অবশ্যই, anaerobic coverage. Anaerobic কি? Very good. So there will be a gram positive and gram negative coverage, preferably a ampicillin is rarely used, amoxicillin, gentamicin and metronidazole. So we'll have to have a very good coverage, both aerobic gram positive and gram negative aerobic and anaerobic organisms. So ঠিক আছে, আজকে কি আর হবে না? স্টপ। তোদের ক্লাস কখন? পরে ক্লাস? আর ক্লাস নেই? একটা বুঝতে পারছিস না? Very simple না? তো এখানে এটা, so what you do is when seeing an X-ray, you follow the outline, follow the contour. That only will give you the exact impression of the bone. তুই যাচ্ছিস এখানে গিয়ে দেখি ছোট ছোট দুটো তিনটে টুকরো হয়ে গেছে, বুঝতে পারছিস? So nasal bone is projected like this. When there is a fracture, there will be small bony fragments outside the main outline. পরের দিনও হলো ভালো করে দেখবি এক্সরেটা। Contour, when you see an X-ray, always try to follow the contours. That is the most important thing in an X-ray. সবসময় just don't see the most important thing. Try to follow it. Even when you are seeing a simple X-ray chest PA view for any lung disease, say we are seeing an X-ray for any respiratory breathing difficulty, respiratory stress, whatever. কি দেখবি? How to read an X-ray? Any X-ray. You start with what? For example, say an X-ray chest.
For airway, B for bones, C for the cardiac cells and associated, D for diaphragms.
See, you always go step by step. That is very good way of seeing it. First, you will see the airway. There's the trachea. Whether it is in midline or not, whether it is shifted to one side or not, that is important. The patient may have absolutely a normal breathing with a unilateral shift of the trachea because of some fibrotic or atelectatic disease of the apex of the lung. We have seen plenty. অনেক সময় দেখা যায়, particularly older debilitated patients অনেক সময় দেখা যায়. Then bones কি দেখবি? Ribs. So কি দেখবি ribs এ? Fracture দেখবি? Fracture থাকলে fracture দেখবো. You expect a fracture, it is just breathing difficulty in a group patient এসছে. So what do you see? Not seeing a second. Okay, good. But that is not something that you see every. It's very rare. So you see crowding of the ribs. You count the ribs based on your pulmonary space. So if there is overcrowding of ribs, what does that mean? Chronic lung disease. So you can see a lot more ribs. Then you see the cardiac shadow. কি হতে পারে? So the shape of first of the size of the cardiac shadow, the shape of the cardiac shadow, the aortic knuckle. আমি তো আর পালমোলজির লোক নই, মেডিসিনের লোক নই, but these are the basics everyone should know. Okay. তারপরে we'll see the other parts of the lung fields, the bronchovascular markings, the basal segments, the costophrenic angles. If you can see any the Carly's lines or something like that, if there is pulmonary edema or something. And then we see the lung fields, if there is any patch, consolidation or anything like that. So always go step by step for any X-ray. Even for ENT X-rays like this fracture nasal bone she was asking. We follow the contour, we come to the nasal bone, and then we see that there are small fragments of bone outside the main line or the main contour. That gives the diagnosis of a fractured nasal bone.